So good afternoon, everybody. Thank you, Manos and Manos, of course, for the invitation. It's a pleasure, this new venue. So my topic is going to be focused more in chronic dislocations and indications. As we spoke about it, it should be easier because we are going to operate those that are not doing well and not coping with their daily activities or sports activities. But the reality with this pathology is the conclusion from many studies and from all the discussion we have here is that there is no consensus about best practices, not even for diagnosis, evaluation, treatment. We can be agree in some statements, but most of the topics about AC joint, they are not really clear, and the failure rate are all over the place in the articles, in between 50% up to 80% in some articles. Claudio, he already summarized. He's with many other members of ESCA, the consensus about AC joint dislocation, and they established the chronicity after 3 weeks. But we have to remember that consensus is based in level 5 opinions from experts, people with a high volume, but still it's a level 5. And as we argue also in the discussion that with Nathan, and the question coming from the audience, there is no like a matter of time. It's a matter of predict the rate of healing or the rate of problematic patients that we are going to have in the long term. So I don't think the issue should be like what is the timing, is more what are the results. And I think he kind of said that I did an extensive review because this topic I spoke about it a few times. I couldn't find almost no publication with a good level of evidence about the result in acute AC joint dislocations. And I would say that if our failure rate is more than 10% with surgery, I think we should do better with this technique. So I went backwards. So I look at the complications of our surgical treatment for operative chronic AC joint dislocation, most level 5 degree or 3B, 4 degrees. And I saw many problems from centers with a high volume of this kind of pathology. So those are experts speaking about it with a high volume and very skilled surgeons. And still they have a lot of problems. So we can imagine the problems we can have in a low volume centers. This Peter Miller is not as recent as others, but still he saw that there was a 27.1% of complication rate and a 23, almost 1 out of 4 is going to require a second surgery, and 62% they had a loss of reduction. I know it doesn't mean a failure, but it still is something that you don't want to see in your X-ray. And this is Peter Miller, we know he's highly skilled and with a huge volume of patients, traumatic patients in Vail. This is another study. This have been done from radiologists. They are not very forgiving to our results, as we all know. And this is what they found. It was a study from a center in New York. New York, normally they have a huge volume as well. They are well trained. And they found in the results in acute and chronic dislocation, a loss of reduction 78%. Distal clavicle osteolysis that we almost didn't talk about it and can be problematic in our patient, 66.5%. And tunnel widening, especially when we do bone tunnels in clavicle or coracoid, 82%. And it was mostly the same with the chronic treatment and biologic grafts using the techniques. Tunnel widening, it leads to, in some cases, clavicle fracture, especially when the tunnel are larger than 4 millimeters. Again, loss of reduction, it continues with failure, osteolysis, same complications. So I summarize all these complications and I try to focus in the main techniques that we have out there. We already spoke a little bit about the hook plate. It's something I never use as some of the most miserable patients I have seen are patients with a hook plate. I know it's very useful, it's reduced. There is a little bit of uncertainty what happened when you remove the hook plate. I'm not experienced enough because I never liked this treatment, but I have seen many patients that had to remove the plate at 3-4 months. I don't know what was the reason for the surgeon to do not remove early after 3-4 months, but those patients, they don't do well, especially if they are sportive patients, until you remove the plate. They have limited motion, they have pain with overhead movements, and the subacromial or the acromial erosion appears very early. The rotator cuff, I think we should keep the plate at least for 1 or more year to have problems in the rotator cuff, but the acromion, it deteriorates very early. Some other problems that are very common for any technique that we use, suture irritation, is difficult, but it's a kind of reminder that we have to pay attention to the details, because sometimes you do a great technique and still you have to reoperate the patient because these are small details. Suture irritation, of course, infection, a little bit more frequent with open techniques. Nerve compression, if we're not careful around the coracoid. Osteolysis, that's something is difficult to avoid, and we may have to do more AC joint resection. Not very aggressive, but probably in more cases, especially in chronic situation or when the reduction is difficult. And some other complications related to bone holes, like tunnel widening, coracoid fracture, which is a difficult complication, clavicle fracture, hardware complication, loss of reduction, and of course failure. So based on that, and also my literature review, what I found is regarding the timing, what is acute, what is chronic, there is no it's still a debate. We don't know yet, and as I said, we should base our decision making in the failure rate in the acute situation using only sutures or suspension device without biologic augmentation. In between open arthroscopic, there is no difference. There is some advantage, as we know, with arthroscopic, but there are some advantages with the open treatment as well, as we spoke about the fascia, etc. No difference in the results in the long term with the studies. Distal clavicle excision, no difference so far in the results, but a lot of osteolysis in our results. Between non-anatomic or anatomic literature favors anatomic reconstruction using looped graft and a suspensory device to give that rest that need the graft to heal in the acute phase in the first 6 to 8 weeks. The graft type, I know there are some literature that says it doesn't matter, but there are probably more articles that say that it matters, and they favor autograft, and based in other techniques where the demand or the strength that we have to contain is high, like this joint, I would rather to go with the autograft in most of my cases. And regarding the horizontal stability, still no consensus, but it looks like we should address this problem, especially in high degree dislocation. So this is my treatment preference based in some of the statements I made before. I try to favor acute reconstruction. I try to favor as much that acute healing. So I try to do this patient as soon as possible. I'm going to use an arthroscopically assisted technique, no holes in coracoid, no holes in clavicle. I'm using an implant-free technique, using a graft, biologic augmentation, and synthetic fixation with third class or suture tape that I loop around the clavicle and the coracoid above the holes. And this is, to me, an anatomic technique. My favorite graft for this is an autologous semitendinous graft, which gives me in between 4 to 6 millimeters of diameter. And I'm going to do a distal clavicle excision, limited distal clavicle excision in chronic cases. I've also seen in these cases that you get some healing, some fibrotic tissue in between the AC joint when you do that limited resection, not very large, because then you lose the stabilizing aspect, because when you reduce the AC joint in the inferior superior direction, you're going to have a limitation of the clavicle to go backwards because of the acromion. So I try to favor that as well. And I do a slow rehab in my patients. So this is an example I did in the lab just to show the difference in between doing a suspensory device stabilization, which to me is a vertical stabilization, which is good. It was good enough. I have been doing it for many years, but I changed and I'm doing a loop third class around the coracoid and the clavicle. So I get a more similar effect to the trapezoid ligament, which is the main ligament that stabilizes the anteroposterior direction. That important, that Claudio said, the horizontal stability We still don't have a good technique. I haven't seen any technique that I like it. I like to spend like 20 minutes like passing like tapes around the AC joint. Also the biologic augmentation that we make with the graph is not a great technique. So we may have to pay more attention trying to replicate this ligament than, but also if we can augment the AC joint as well, is good as well. And that's what I do right now. I do 2 loops with a third class through the coracoid or around the coracoid and around the clavicle. I try to cross both loops, and then I'm going to do a figure 8 technique with my semitendinous graft. And I try to summarize also the technique with this video. There was a type 5 patient that was a semitendinous autograft. That's the kind of dissection you have to do of your coracoid if you do an assisted arthroscopic assisted technique. You use shuttle sutures to pass your 2 third class. It's very useful, the tensioner, because it's very difficult because you are a little bit deep in your technique. So it's good to use the tensioner, and that's the configuration you can see. And then in this point, you have reduced the clavicle, and you can put your graph easily because the reduction of the dislocation is already done. So you put your graph inside in a figure 8 configuration. I tried several configurations. That's the one who works better because that's the one that you can really tighten up and then put your sutures. But sometimes the technique is in the details. It's not easy. Sometimes I think our techniques have a loss of reduction because it's not easy to tie the graft, to put your sutures, and as you have seen before, I do like extra portals to have like a perpendicular direction to my graph to tie the graph and to put my sutures. And that's the kind of results that hopefully is gonna last in our patient. Thank you.
Thank you, Gonzalo. I think we have time for only one question, if there is any. Yes.
Congratulations, Gonzalo. We are the only 2 Spaniards, so it's appropriate that I ask you a question. So the 2 previous speakers have said to us that the AC joint repair is essential, that you have to look at the deltotrapezoidal fascia and try to repair the AC joint ligaments, and you don't seem to do that. Mm-hmm. So why do you disagree with them?
Well, it's not that I disagree, but I mean, we haven't done anything in the AC joint for many years, and still the technique was working properly for many years. No, I agree with authors that say that we should do something in the AC joint. I just said that I haven't seen still a technique that is easy, that is reproducible, and doesn't use tapes or third class or something without biologic augmentation. To me, it doesn't make a lot of sense, and it's not adding a lot to my surgery, and that's why I'm not doing it. I agree something should be done, it would be ideal, but I haven't found a good technique. So what I said is that what I'm doing is I'm trying to replicate the trapezoid ligament, doing my loop configuration, and with that, I think I'm getting better horizontal stabilization than before with the suspension device, and also in the chronic situation, I try to favor the fibrotic tissue that you're gonna get with your limited AC joint resection. I wouldn't do like a 1 centimeter. I would go just for the minimum 5-6 millimeters with your burr, and that's the way I try to manage the horizontal instability.
Gonzalo, can I just add one thing to that, what you just said? Yes. Just one comment to that, because for the horizontal instability, it's really something that is important for me too. So he kind of overcomes this whole scenario with his cerclage. So we know if we do a double button technique, we don't have to address as much the horizontal instability on the AC capsule because we have a much stiffer construct between the clavicle and the coracoid, but also avoids horizontal instability. As soon as you put 2 different things at the same spot, they add up. It's kind of the crucial ligaments. You have an anterior and a posterior bundle, and you also prohibit anterior-posterior translation. You have to do something to the AC capsule as long as you only have one strut that goes up and down. That's the difference. As long as you do multiple struts, like you do your cerclage and a graft, you'll be fine. Would you do just one of them? I would appreciate if you would do something to the horizontal instability on the AC joint.
I will in the future. But still, the technique, what I don't like is too many holes. You know, you have seen the catastrophic failures you can have. So we have to be aware of that. Have to be small holes and at least 3-4 centimeters from the AC joint to avoid the risk of fracture.
Okay, thank you very much, Gonzalo. Let's move on to the last talk of this session. Mr.